Okay. So for somebody who has not slept well, you can do for next 15 minutes because nothing has changed much. I will be discussing this in the following headings. Introduction, how to prepare the patient for labor and delivery, how to manage during labor, and what are the issues during the postnatal care, and what to do about the newborn and follow up after delivery. Now, we all know that diabetes is a big problem, especially for in the gynae setup. Good morning, everybody, and thanks to the chairpersons for the kind words. First batsman of the Magna Endocrine update, thanks to Dr. Rama for the invite. In the next 15 minutes, I would say I would be telling about the topic which has not changed for past at least 50 years. The last obstetric and gynecology clinics of North America management of diabetes during labor was published in 1989, and that holds good even as on date. Okay, so for somebody who has not slept well, you can do for next 15 minutes because nothing has changed much. I will be discussing this in the following headings. Introduction, how to prepare the patient for labor and delivery, how to manage during labor, and what are the issues during the postnatal care, and what to do about the newborn and follow up after delivery. Now, we all know that diabetes is a big problem, especially for in the gynae setups, obstetric setups. Majority of that is thankfully gestational diabetes, almost 99%. Minuscule number is type 2, further minuscule is type 1, and other types by and large are not there at that time. The only concern as on date is actually when you look at the prevalence, mostly the numbers are more because most of the girls or ladies are opting for pregnancy in the late 20s or maybe mid 30s. That is the time you are at such a higher age group, you are higher risk of having a diabetes as a population risk, so you would have an increase in the gestational diabetes also. Obviously more complications, I will not be discussing all that. To come focused onto the topic, one of the key factors which concern the obstetrician is actually when you give a steroid. What happens when you actually give a steroid, and then the concerning the hyperglycemia at that. Most of the times this is given at the, most of the times this is given at the time of 34 plus or minus weeks for the fetal lung maturation. If somebody is using is on only diet control, the steroid induced hyperglycemia effect start taking from the second day onwards. So first day you may not have to do anything, but you need to monitor closely, especially the post meals to start with and the fastings thereafter. And after somebody who is already using an insulin, the first day of steroid administration, you may have to continue the same dose, but from second day, third day and fourth day, you need to up titrate the baseline dosages what you are using almost to the tune of 40%. So that is just to cover up for the steroid induced hyperglycemia. When you come to the delivery aspects, what are the general considerations? Gestational diabetes, when to deliver is always a debate. We will discuss in the next subsequent slides. Pre-gestational, that is either type 1, type 2, generally 37 to 38 is acceptable. Some of the guidelines I will talk about subsequently, but generally don't look at keeping them till term. Unexplained IUD is something what we all are worried, whoever is practicing in this field, because despite having good control, despite having close monitoring, there are some mishaps happen, and which is very difficult to handle at that point of time. You should always keep the anesthetist in loop because you don't know when the patient is likely to land up with cesarean, what sort of anesthesia you're likely to use. So just have a peri-anesthetic checkup is important. Some of these complicated deliveries, preferable to have the neonatal resuscitation team also standby or in the close vicinity. Now, when to plan for delivery, there are two schools of thought which actually says that what are the considerations when you look at. Before 39 weeks, definitely if somebody has got past history of IUD, you already have a macrosomia, maybe more than 4,000 grams. Somebody who cannot reach you close by, maybe a decreased movements felt or membrane rupture, all those things, if they are located 2 hours, 4 hours away from the hospitals, you would try and deliver them early rather than keep on waiting for 40 weeks. Obviously, for glycemic related, if there are uncontrolled diabetes, any other complications, you should consider delivering them early. Keep them good till about almost 40. If there is no obstetric complication, things are going smoothly, growth parameters are normal, well-controlled diabetes, even with the tablets or maybe a diet. Insulin-treated patients generally are not kept till the term. Okay. What do guidelines recommend about when to deliver? Can anybody read on this slide? So guidelines are also not clear. Nevertheless, the ACOG, it only tells that diet management up to 40 weeks you can wait. For somebody who is using drugs, 39 to 40, and you should definitely go for cesarean if your fetal weight is more than 4.5. Nice guidelines were actually nice. They just said deliver before 40 weeks. You don't have to bother about the diet, you don't have to bother about what sort of medication, but it is just giving a blanket statement that before 40. FIGO again looks at induction more than, if the estimated fetal weight is more than 3,800, and maybe with good control you can wait till 40. So by and large the consensus is you can wait till about 40 if everything is good, otherwise early. Key considerations in the labor, mostly the mothers are kept actually nilparvolar at that time. So it is important to look at their glucose, look at their insulin, what they have been used previously. Okay. Glucose turnover increases because the insulin levels comes down, or the activity, the muscular activity increases. So you are actually utilizing more glucose without the help of an insulin at that point of time. When to stop oral feed, when to continue oral feed, again some of the prolonged labor issues, or when you are converting an observant mother from labor, taking up for an emergency LSES, all those things are important. And insulin requirement drops drastically the moment you deliver the placenta. So again, you look at, be vigilant about the hypos at that point of time. Most of the guidelines agree that you should keep a target of 70 to 120 throughout the labor period. If you are planning for a C-section, preferable for any diabetic mother to be first case of the day. You should omit the nighttime insulin in all GDM patients. Okay, reduce it by 50% in pre-gestational diabetes, because most of the gestational diabetes, you don't require that much support, especially beyond 36 weeks. And if you are taking up in the morning, you deliver early, so that longer acting insulin is going to further act almost to 24 hours. So it is always better to stop the previous night. Neutralizing drip in some, when you have a prolonged issue where you give some amount of insulin along with the 5% dextrose to control both glucose level as well as the insulin, especially mostly applicable in some type 2s. Type 1, we don't do this because we want them to be separate infusions. I'll come to that later. Avoid hyperglycemia, especially in that setting, because the moment you have hyperglycemia, more insulin is released, more glucose gets across to the neonate, who releases more, and the moment the fetus is out, the neonate, there is higher insulin in that spectrum, you have more chances of neonatal hypos at that point of time. So preferable to stick to a range of 70 to 120, and beware of the long-acting insulin, which may cause hypos unexplained in the post-surgical period, where you are actually other things to handle, but glucose is neglected often at that point of time. If you have to induce the labor, again preferably first case in the morning, all diabetic mothers. The night dose by and large is taken normal. You have a early breakfast, you have a light breakfast, and you may have to give a 50% reduced dose of the prandial insulin of that particular day. And prolonged labor, if you are keeping them nilorally and glucose requirements are there, you parallelly start the glucose infusion. And if there is a hyperglycemia, you start insulin infusion if GRBS is more than 140. Now, when you give glucose, it is by and large 10% dextrose infusion. The boluses are given 50 ml per hour and continuous infusion, which is continuously given. Potassium is generally not added. Potassium is only added if you have a baseline hypokalemia or if the duration of action is beyond 10 hours. If you at any point of time during monitoring documented a low blood sugar, you have to give a bolus dosages of the same thing. Insulin infusion, again, you give mix 50 units of insulin, regular insulin with in a 50 ml infusion pump. 1 ml per hour will be the infusion rate, and different protocols exist. I'll show you one, but generally you have to check hourly glucose, and if it is less than 120, you may not have to give any insulin infusion, but more than between 120 to 140, 1 ml per hour, and beyond 140, 2 ml per hour is general recommendation. If the expected drop is more by 50%, you may have to down titrate the infusion. One of the protocol from the University of Northwestern Hospital, most of this is managed by the nurse practitioners who have a set pattern as to document the glucose, adjust the rate accordingly. So if you have a checklist sort of thing functioning, it is easy to handle. You can see how you are changing and what is the glucose values which you are managing at the other end. Okay. Some individual considerations depending on what type of diabetes you are dealing with. Gestational diabetes, by and large the targets remain same between gestational, pre-gestational diabetes. As I said, omit the basal insulin, and most of the times gestationals don't require insulin during labor. So don't give unless your sugars cross 140, 150, because they're more prone for hypos at that point of time. Type 2 who have been using metformin, you have to reduce your basal by 50%, and you have to give glucose insulin infusion separately if required. Monitoring can be a bit less because these are young type 2s, so their insulin reserves are fairly okay, so you may not have to have more close monitoring. Most problematic are the type 1s who are actually young and who don't have any insulin in their system. They are more prone for ketosis at that point of time. These are the people, it is mandatory to have a glucose infusion separate and a insulin infusion separate, so that you can adjust both parallelly, and don't stop the infusion forever in type 1 till they start their oral, till a subcutaneous insulin is on board, because they are obviously without insulin they will go into ketosis. So you require to continue the insulin infusion in all type 1s. How to look after the newborn. Glucose more than 48 is considered as normal. Immediate and 2-hourly checking is required, and preferable to feed within 30 minutes. Depending on the echo, depending on the assessment prior hand or the complications, you may have to look at magnesium, calcium and other things, and a echo if required, or if there is a suspected cardiac malformation. At least 24-hour observation for all gestational diabetics and their newborns before you discharge is mandatory. Don't be in a hurry to discharge even if it's a normal delivery. Post-delivery breastfeeding is mandatory, there is no doubt about it. Some of the ladies still have, may not be from this part of the world, but most of the patients do have the fear that they may transmit the diabetes to the baby. So educate, it is our job to educate them that they will actually prevent the risk of diabetes rather than transmit the diabetes. So it is important to educate. There are some studies to say that lactation improves the glycemic control as well as the benefits for the offspring also. Long-term risk education is important, and babies born to mothers with a GDM have a higher risk of metabolic disorders in future, important to understand. And any method of contraception, GDM, history of GDM is not a contraindication for a OCP, so whatever the patient is comfortable, educate about the contraception as well. How to follow up. Most of the guidelines say that you should do a OGTT at 6 weeks. OGTT doing at 6 weeks is actually a very difficult thing to do. So some of the NICE or other people have said fasting, or some have said even A1C. At least will give you some clue as to what you are likely to have. Obviously, the just mothers have a higher risk of type 2 DM in future, almost 5% per year, and a recurrent gestational diabetes, again a higher risk. So you should educate about the lifestyle, weight, and possibly some of the guidelines now start accepting or giving metformin in this pre-diabetes phase for an expectant mother. So last slide. Mother with diabetes is ideally delivered before 40 weeks, there is no doubt about it. Differences between the only diet controlled and some medication related GDMs are important. Maybe 40 or 38 should be the ideal one. GDM per se is not an indication for cesarean. It is definitely an obstetric indication depending on whatever is the pregnancy. Just because somebody has diabetes, nobody is taken up for surgery. And beware of the physiological changes at that point of time. Be more dynamic. Frequent checking is the only way which will help you, and possibly having the two different infusions also will help you. And adequate preparation is important, and this is a time where the ladies are more receptive, so educate about the long-term risk and the implications of having a diabetes. I have finished here.
Thank you, Dr. Hari Kumar. That was indeed a very elaborate and detailed discussion on management of GDM and pre-GDM in labor and postpartum. We'll take the questions at the end of the session, Doctor.